Welcome to the Stuck Pig Academy of Medicine. We discuss all things medical preparedness with a focus on austere care. These episodes are recorded during my Patreon classes. If you are interested in joining, use the link in the show notes. This podcast cannot and does not contain medical or health advice. The medical or health information is provided for general informational and educational purposes only and is not a substitute for professional advice. Accordingly, before taking any actions based upon such information, we encourage you to consult with the appropriate professionals. We do not provide any kind of medical or health advice. The use or reliance of any information contained on the podcast is solely at your own risk. All right. Welcome to another episode of the Stuck Pig Academy of Medicine. Today we are going to be going over Chapter 4, continuing our review of the much recommended Where There Is No Doctor, a Village Healthcare Handbook. So we're on Chapter 4, How to Take Care of a Sick Person. There's some really... And I say this, I'm pretty sure I've said this every episode so far, but there's some interesting stuff in this chapter. And the further we get into this, the less and less we have to deal with some of the political issues in here, which is always beneficial. There's an interesting documentation that this chapter references that I'm going to have to see if I can find blank forms online to throw up a PDF or something on the site to add to that reference library. But all in all, a fairly decent chapter, and a lot of stuff that I feel has been lost over time, especially in the U.S. with this buildup of our industrialized medical care. Just one of the things that we've lost is the in-home knowledge of long-term nursing care, because it's just one of those things that we've outsourced, good, bad, or indifferent. It just is one of those things that we have lost.
Yeah, I mean, I think it's economy of scale at this point. Not that this is an economics discussion, but at this point, it's like it's cheaper for people to go work a job and pay for nursing home care or whatever quality, than to have the opportunity cost to go work versus taking care of their family at home.
Yeah, that's definitely, especially with things like insurance and stuff like that, kind of offsetting the cost of some of these things.
Long-term care insurance is absolutely horrific as far as actually having decent coverage for doing its job for long-term care.
I think there's a cultural element as well.
Sure.
We in the U.S. we've largely lost the intergenerational relationship.
Mm-hmm.
We've been very successfully separated one generation from the next, versus like I grew up with friends who were from the Indian subcontinent, and they've got grandma lives with them, and then you got 3 generations of family in the same home, and it's not just those folks. There's lots of folks from all over the world, and it was just part of the culture, and just probably a result of the necessities of life. And it wasn't a burden, it was just part of what they did, and you're gonna enjoy the benefit of when the kids are young, you got kind of built-in babysitting and got that perspective from having grandma or grandpa or both, and they're at the house. But Americans have been very much sold on the mythos of the rugged individual.
Yes.
And this is both from a community and neighborhood standpoint and from a familial standpoint.
Yeah.
I was going to go with the empty nest situation, but
yeah, that too. I mean, you combine how many of the boomers sold off family farms they saw dollar signs, and then how many of them are getting reverse mortgages and things put on their houses, so it's almost impossible to build generational wealth. That there is no home for anyone to get when mom and dad pass on, because they reverse mortgaged it to go get a timeshare in Cabo so they can spend their winters there.
Yeah, I'm not an economist or an historian. I do enjoy the YouTube channel What If Alt History. That's actually pretty interesting on these kind of topics.
Yeah.
But I know that this is not a it's not the that's not the main focus of this discussion. So
No. But the cultural ramifications, or I'm sorry, let me rephrase that. The long-term medical care ramifications of the cultural shift
oh
in the
yeah,
last 50 years is
we're
hard to be
definitely not working
ignored.
in a vacuum for sure.
Yeah.
Yeah, that's valid. I just don't want us to get too far off track.
Oh, absolutely. So starts off with a very interesting the first part in bold. The care a sick person receives is frequently the most important part of his treatment. Right now, we're used to a model where there's a quite hefty care team involved in the care of most, especially more extreme cases. Most of what you see, like in a hospital, a little bit more of a well-rounded, or not well-rounded, but more of a substantial care team involved. Of
Interdisciplinary.
yeah, multiple people from multiple different backgrounds, varying levels of education coming together
Yeah,
to
so like in
work
at
on
the
this person.
like the ICU level, the intensive care level, you've got physicians or physician assistants, nurse practitioners, nurses, nurses assistants,
Mm-hmm.
respiratory therapists, physical therapists, um, as well as like
There are many different layers of doctor.
well, yeah,
Yep.
you got various levels. I kind of put all the physicians in one clump, all the specialists as well. You've also got janitorial staff. You got the catering. You've got like all kinds of folks that are participating in that.
Mm-hmm. And we're gonna have to replicate at a much lower level, just some of the basic care things. But it just kind of shows how important some of this stuff is.
Mm-hmm.
Um, and it's really not intensive, crazy stuff that we're talking about, or that this book is talking about. Like they're not talking about like multi-panel labs and crazy imaging that takes up an entire building all on its own. It's pretty basic stuff. I just thought that first part that it highlighted was pretty important. Then it goes on to say that medicines are often not necessary, but good care is always important. Um, the following are the basis of good care. So it starts off with the comfort of the sick person. And the thing I highlighted on this was the plenty of fresh air and light. And I wrote down next to that windows, specifically drawing on like some of the third world stuff where they don't have central air. So they use separated buildings with large open windows to get natural airflow and natural light in.
That was a point that Dr. John Campbell was talking about a couple of years ago at the height of the COVID scare. Was like, why don't we, like it's understood that air movement reduces viral load, right? It's one
Mm-hmm.
of these things like if you have any kind of contagion, um, then like air movement and circulation is going to reduce the potential for the contagion load. But our hospitals are very much closed systems
Yeah.
here in the West, and we've gotten to the point where we kind of think of that all hospitals must be closed systems.
Yeah.
To the point that I've heard physicians in the U.S. comment on how not having a closed system means someplace can never be a functional hospital. And after I spent undergrad time in a sub-Saharan African hospital where you did air conditioning by window in the OR.
Oh, wow.
Yeah, but they had a very low post-op infection rate. And
I think we
wow.
I think we also need to look at the larger context of that. All right. So in the US, hospitals are in cities. Cities
Mm-hmm.
have a lot of pollution, they've got a lot of noise, they are not clean environments. And where we were, it was rural, it was very relatively quiet. You didn't have any of those issues. It wasn't the middle of a city.
It was also tropical, so you don't have the big dust problems.
Mm-hmm.
Like where I was in Africa is like we were not in a desert. It was sub-Saharan. It was temperate. but it was dusty. Nothing was paved. You were lucky if there was gravel. There was dust everywhere, and it's one of those places that if you leave food uncovered for an hour, it's going to have a visible layer of dust on it. And so it's like you got that. You got all these pathogens that float around the dust, most notably there, like tuberculosis. That's a tough bug. It will live in dust for weeks. So you do have legitimate things where it's like, you'd prefer to not have this drifting in your windows during a sterile procedure. Yeah. But it's also like bearing out in the real world, like how often is it causing a problem? Well, next to never, so we're going to keep going.
Yeah.
So I think this blind adherence to a closed system you must have a closed system for your hospital is just that. It's blind adherence. It's just like,
I think so.
What Scout would call a Pakistani hamburger.
Mm-hmm.
It's a hamburger with cabbage leaves and not lettuce because it looks the same.
Oh.
Because like this person who doesn't.
When all you've seen is pictures of something.
Yeah. So now that I've ticked off like every person in American medicine that might listen to this.
Not really too worried about their opinions.
Well, I think the point there is with your, at least at a facility level, you adhere to the highest level of capability that you can, but since you are not in a first world ideal setting, what you can goes downhill in a hurry.
Yeah. You
and then you find out what works.
Yeah, and you learn quickly where to best spend your resources. And your time and energy.
Yeah. Exactly. So just because you can't recreate a level 1 trauma center doesn't mean that we give up and like, oh well, we can't do that, so we can't do anything. Like there's a middle ground.
Yeah, I am obligated just to point out that a level 1 trauma center, the only difference from a level 2 is that a level 1 does research and publications. Level 2s just don't bother, but they do all the same medicine.
But level 1 trauma center rolls off the tongue.
It does, and it's a thing that most people, because everyone watches like medical dramas, so that's what they know is like top tier. Like when you talk about soft, like they don't think of like LURs and like Rangers and like no, they think of like Delta and like DevGru and shit like that. Like, so I get yeah.
Sorry.
No, you're fine.
That's funny. That is probably one of your more favorite things of like, well, just so you know.
Turn around too much.
Oh man.
So anyway. But yeah, there are whole fun phrases to throw out like level 1 trauma center.
Yeah. That's the big one that people know what that, or they might not know, but they know it's serious.
They recognize the buzzword.
Yeah.
Yep.
They know just enough that they realize that that's like important. But we don't have to recreate even just an industrialized hospital to be able to provide competent care and have a positive impact on people's lives, because that's ultimately like what we're trying to do with all of this is have a positive impact on people's lives when everything else is going to shit. Like, you could just sit in your hands and be like, well, I don't have all the autoclave and all the things and the drugs and the formulary. And it's like, okay, you can sit there and whine, or like we can try to do something. Like I might not have an autoclave, but I've got a pressure canner.
We can do it a lot with a pressure canner.
Like there's a lot there. Man, I really need a soundboard because there's another thing I had another little clip. It's from an animated movie. I may not have a brain, gentlemen, but I have an idea.
I know what you're going to be doing for Christmas.
Oh yeah, there's going to be a soundboard edition. I'm trying to get like an actual desktop, so I'm not on like an old used laptop. So there'll be like an actual like real computer, and I'll have like some ability to do things.
I don't know. I kind of feel like if you make spam like too nice, it's charm.
Well, if you're gonna bother naming it spam and keeping that name.
Oh, I can't think of anything better than that. That is the perfect name for this.
My point is you can't make it too charming.
Oh no, I don't want it too charming. I just want to be able to add in stupid audio tags.
Well,
just for humor value.
Well, I always think of old Remus as like, he was a big fan of Spam. So there we go. The Woodpile report. All right. So these elements, the following are the basis of good care, and they are numbered: one, the comfort of the sick person.
Yeah.
That kind of back to like, are they able to sleep essentially?
Yeah. And that's where the plenty of fresh air and light. And then we have liquids. And the favorite phrase of any any DoD medical personnel: drink plenty of liquids, specifically water.
And next, personal cleanliness, change your socks.
Yeah. So the thing that I highlighted here is clothes, sheets, and covers must also be kept clean. This talked about, because this is just the basic stuff. There's also, like, later on in this chapter, it talks about special care for a person who is very ill. I don't know why there's like this first part and then they just basically repeat it all with extra steps.
I'll try here. So all right, let's go over it. So first is these principles are comfort of the sick person, liquids, personal cleanliness, and good food. And then they go to the special care for a person who's very ill. So liquids is one, food, cleanliness, changing position in bed, so and watching for changes. So the first three, liquids, food, and cleanliness, that's pretty much a reiteration of the things from the original. Changing position in bed, if this person is that seriously ill where they can't move themselves.
Yeah. So I guess what I was getting at is why couldn't they just have like, these are the basics and then like these are the extra things for someone who is,
instead
like,
of just
why they just like reiterating it over it. It almost seems like they're kind of talking down a little bit.
I think there's both a benefit in it's like, if you hear it again, you're more likely to remember. And
okay,
they go
fair.
into a little more detail, like with the liquids, like just talking about giving sips for someone who is awake and can protect their airway.
Yeah.
And it's like just getting into finer level of detail there.
So if you hear it more than, if someone says it more than once, it's important. Also, this is, I think, a collaborative project.
Okay.
I think it's a collaborative project because mine says David Werner with Carol Thuman and Jane Maxwell.
So you might have had different people on different sections.
Okay.
So you might have some redundancy there. Would be another
That's fair.
I can't say one way or the other.
Yeah. The other thing I highlighted was a sick person should be bathed each day. If you've read through the prolonged field care CPGs, it actually talks about this. It talks about like doing a sponge bath, basically, or even just like a baby white bath, which is like colloquially, if you were like DoD or even outside, referred to as just a whore bath. Like, you're just wiping the places where you sweat a lot, just to kind of.
Heard that term, yep.
Yeah. So even just something as simple as that can have a pretty big impact, because the last thing we want is to like, hey, yeah, you came in with like a pretty nasty stomach bug and now you're leaving without the stomach bug, but now you have a pretty bad case of jock itch. Like, that's the last thing we want to add.
At the risk, at the risk of TMI, it's not that bad. When I was at the Jaeger course, Mike talked about prickly heat,
yes.
which I was not familiar with. So
it's
on the drive west, I think I ran into that because I just like kept sweating and I was sitting for hours in the truck, and I think because it was like, man, I was itching, like my lats and the bottom of my thighs were just itching and they were red for several days after I finally stopped driving.
Oh, I'm trying to remember what the actual name of that is.
I don't even know what the actual name of it is.
Because it's where like you're sweating so much that the sweat dries.
And it
clogs the pores, and that the crystalline, like the salt crystallizes in your pores.
Yeah,
and it's painful.
Yeah.
I've witnessed this twice firsthand. I personally got it during Hurricane Florence, because we had to wear a life vest everywhere. Weren't showering for a couple days, and that plus the brack water and all the other things combining together, like, I had it bad on my back. To where like a light breeze would like flare it up. The other time I saw it was NTC, when dudes had to wear armor for 10 days straight. And what works really well is you just take like a credit card or like a hard plastic card and you scrape. It's not gonna feel good, but what you're doing is you're clearing those pores, the sweat pores out.
Scout should put that as an added feature of the Range-R cards.
Ooh, I think that might be a little too. It's not like flexible enough because you need it to kind of like follow. You don't want it. That's a little too stiff. But the reason we always said ID cards is because everyone always had their ID card on them. But like a credit card, or like one of the, like, you get like the card in the mail, like, hey, sign up now and you can use this card, or like the gas station rewards cards. You can just keep one of those like in your hygiene kit or like in your assault pack or something, and you can just kind of scrape down their back, have them use theirs, or you use theirs on their back in areas they can't reach, and that can make a world of difference because comfort is a motherfucker.
I think it seems like minor things when you're sitting comfortably and like talking about it, but when you're out trying to do things in the real world and there's this minor irritations, they stack up and they really being able to perform.
Like treating your socks with permethrin and wearing gaiters when you go out into the bush so you don't get bit 47 times on one leg by chiggers and are now suffering with it 4 days after.
It's a very specific example.
Very specific, and I would have no idea how terrible that is.
Yeah, very specific and totally theoretical.
Yeah, completely theoretical. So yeah.
So I guess going back to these first few pages, trying to keep people comfortable, hydrated, clean.
The good food is important. One thing I found frustrating with that first thing of food, where it's number 4, good food, how the food that they were referencing was all carbohydrates.
Quick energy.
Well, like it also, like, and they mention it in, for someone who's very ill, adding, basically protein, egg, beans, well-chopped meat, fish or chicken, into the diet. That's really important. Oh God, I'm forgetting the name now. Oh man. The drummer for Sum 41.
Yeah, you lost me.
I'll think of it later. But he's a vegetarian and he got really, really sick. This is like years ago. And like couldn't get over it, couldn't get past it, and just started eating like a small amount of meat. I think it was fish specifically. He introduced back into his diet like once a day, and within like a week was over whatever thing he had going on. It just, like, not to forget like how important protein is in the diet, especially like when you're trying to heal.
I was gonna say wound healing. Yeah.
When you're rehealing tissue, it's kind of.
Oh yeah, so that that is a good point. I think you're more likely to get somebody who's not willing to eat initially, more likely to eat something carbohydrate.
Yeah, like a brat diet.
Yeah, it's easy, or like something sweet or sugary or just easy to digest. So like just getting calories to start with, and then you graduate them to protein.
Yeah,
when they can, absolutely.
I don't know. I guess it's just because they're just trying to, I guess it's some of that lowest common denominator, or there's assumptions that are being made with how they're defining sick person versus very ill, that aren't translating.
Well, I mean, I'm also probably not going to be too worried about whether I actually get them cassava, as it's mentioned here. I know that we've discussed before, this is for their context in the mountains of Mexico. So
but I think also the difference being if we just, as I read through this, I kind of arbitrarily assigned like inpatient hospital for sick versus ICU for very sick. If you kind of take that route, inpatient hospital, you know what, they've got a lot of reserve. They're not dying. They're not in imminent danger of dying. If they don't feel like eating, I don't really care because they have that reserve.
Now.
Yes. But the point is, they should always be well enough that it's like if you were trying to get them back into the whole habit of eating, they will still have that reserve.
That's fair.
If you're talking ICU level, they have lost that reserve just because of the stress their body is under, even if it's not a prolonged duration. So that's when you're really trying, like, what they're talking about is this is a really backwards way of explaining it, but it's how my brain is processing. is like the nutrition for the very ill or critically ill person. They're talking about doing oral TPN. And to explain what that means, TPN is total parenteral nutrition, which is a very fancy soup that gets cooked up in the pharmacy and goes in through usually a PICC line, so a central line, into a big blood vessel and gives you all the nutrients that you need. It's for someone
directly in your bloodstream.
Yeah, it's for someone whose GI tract is not working. But the point with it is it's a very specific mix of carbs, fats, and protein. And the protein goes up the more the person needs to grow or heal. So it's like the discussion of the nutrition for the critically ill in this is more talking about like making sure you're getting that protein to be able to rebuild tissue and to be able to get your ratios of the different food groups that you actually need at that point when you don't have the reserve to be taking it out of your muscles or something like that. Sorry, that was a long-winded way of explaining that.
No, it makes complete sense. And looking at it that way does start to make a little bit more sense with everything.
Be good to have a nutritionist to kind of talk
It
about
would,
that.
yeah.
That kind of thing too. Because that's what they do. That's what they do.
Yeah.
It's their bag.
All
right. So we've I think we've other than talking about the specific diets for anemia, stomach ulcers, etc.
I wanted to point out some things on the liquid rehydration I was talking about. It's basically talking like any kind of liquid that you can get into someone is great, which in a general sense is very accurate. But just wanted to point out that for diarrheal disease in particular, and this may be info that was not published at the time that this was. I don't know how recent this is, but it is now incredibly discouraged from giving juice and tea in diarrhea because they're both osmotic. They're more concentrated themselves than your bloodstream is. So when those things hit the intestines, they actually draw water in and they dehydrate you further.
Yeah.
And they can prolong diarrhea because they're just adding more liquid to the intestines. So it doesn't prolong the infectious course of disease, but it does prolong the symptoms and the dehydration.
Yeah. If you're going to do something like that, at the very least, dilute the shit out of it.
Oh, yeah.
But that's, and the rehydration drink that they talk about is fairly decent. There's a lot of sugar in it, so depending on where they are in that dehydration stage, there's a chance that that's going to make them vomit.
And you can always cut the sugar, but the more important salt. You're just doing sugar for calories and taste.
Which is why I heard from an SF guy to carry salt pills. Because they can just take that salt pill and then sip water, and they're way less likely to vomit that up than they are some sort of oral rehydration solution. It also tastes like shit.
Okay, it shouldn't.
Most commercial, well, not like literally, but like it's not a pleasant. At least like the oral rehydration, like the ORS that we had before we started buying the commercial stuff. The ORS that we had on the DoD side was not that good. It was like really salty.
I'd like to try Drip Drop. I have not.
It's a game changer. The watermelon is my personal favorite because it tastes like watermelon Jolly Rancher.
Okay. Speaking of consumables, there is like 5.25 pounds of non-CBD chocolate covered gummy bears in the fridge now.
Yes, perfect. Excellent.
Anyway, legal in all 50 states.
Yeah.
So,
in a pinch, if you can't find Drip Drop, Liquid IV works really well. I've used that. I've given it to people.
Pedialyte.
Yeah, Liquid IV is one of those.
Pedialyte's got a lot of sugar in it, and I've seen some people have reactions to that. It probably works better in peds. It's also a little bit more expensive.
Yeah, it works. It actually works exactly the same way. I have the recipe for Pedialyte, like the actual combination for it.
Huh.
It's a bunch of sugar. Teddy has done a lot more research on who has more sugar and what. but there tends to be there is, at least in kids, and I want to say this carries to adults, but I haven't seen the research on it. There's less vomiting with Pedialyte than with straight water.
And it goes better chilled.
Oh yeah, it's way better chilled.
You said before it goes better.
Yeah.
The powder is better than the premix, and and then either of them are so much better cold.
Yeah. I had some complaints with the liquid IV powders that I brought to the Jaeger course, like taste complaints, which I was like,
okay, come on.
But I don't get it, but no one ever accused me of like having like really refined taste in most things.
Now I'm the unicorn who likes Pedialyte.
It's like I will fight you over chocolate or coffee, and there's not a whole lot else like that I really know very much about.
That's a weird thing to complain about. Okay. I mean, I guess it's personal preference. You can get the multi-packs of the different flavors and people can figure out what they prefer. I know the Air Force has had a lot of really good luck with the Ceralite and the Cerasport, spelled with a C, Cera, and then light is Lyte. That stuff is rice-based, and the Air Force research and development labs have done tests with it and traced the absorption of it all the way to the large intestine. And like the very end part of where water is absorbed, they've traced like that being absorbed all the way down to there.
I'm trying wasn't there like a rice-based liquid that they talk about earlier in this book, or am I thinking I may be thinking of Dr. Lee's book?
There might have been.
Because he talks about oral rehydration as well. I don't recall. I've been reading enough of this stuff recently that it's all starting to blur together as to where I find things. I do appreciate in his book, he actually talks about the sodium glucose co-transporter as far as like why you need sodium and glucose.
Yeah.
Mm-hmm.
Yeah, you
both so that they'll take them, so that the glucose is there, the sugar is there to help the sodium get where it needs to go, because that's that membrane transporter takes both of them in at the same time. Needs some of both.
Yeah.
Not really a discussion of taste.
Equal amounts, but
yeah. and if we really want to get into the weeds, if you got a diabetic who's on a SGLT2 inhibitor, like empagliflozin, anything ending in flozin, that is the second identified type of transporter. It does not affect, and that is in the kidney. SGLT1 is in the kidney and the gut, and SGLT1 is what we're talking about. So basically, you can still take your oral diabetic meds and not
rehydrate them
and not interfere with this oral rehydration solution. That's not going to be a problem.
Yeah. Yeah. Wow. That's
getting into the weeds there.
It's important.
As disclaimed.
Oh yeah, important though. On cleanliness, I know I've brought this up and I've been corrected. This is to kill any viruses or germs for handling soiled or blood-stained clothes, bedding, and towels. It says to just wash them in hot, soapy water. You need to boil the shit out of it. Especially when we're talking like dysentery and some of those other fun, nasty things that we haven't seen in the States for a while. Boil the fuck out of it. Stick it in that big stew pot you got for low country boils and just let her rip. And just let that thing boil. You can add chlorine bleach. Still working on getting a generator thing figured out.
I mean, if you've got like, oh yeah, that's cool. I mean, if you got, like, let's say you're taking some care of somebody for pneumonia. Like, okay, maybe you can get away with soap and water for washing their bedding. But like you say, if you're dealing with something like a cholera or other area, like, yeah, no, you absolutely need to boil that.
They would probably just be safe practice with the lack of understanding. Just boil everything. It doesn't need to be like an hour or 30 minutes, but like give it a good 5-10 minutes boil time.
Rolling boil
in the water,
and that is, again, if I recall correctly, that's below 3,000 feet, because Above, I don't
Yes.
know I don't know the math, like above 3,000 feet. Above 3,000 feet, a rolling boil can happen at a lower temperature than what you need.
Yeah.
I don't know how that all works. I guess you go to a pressure cooker above that, but
Yeah.
anyway.
But yeah, just boil. Just as just to, because you know it's, I would rather err on the side of caution in this situation. Because what does it cost you versus not erring on the side of caution, and what that can potentially cost you.
Right, just some
So
extra soap, basically.
yeah,
Like
Time,
soap.
fuel.
Yeah.
yeah,
Well, soap and water, which I'm assuming you're gonna heat the water. I guess that was an assumption, I guess, but mostly that soap. Okay, so I think we've pretty well. We talked about watching for changes. We talked about changes last time.
yeah.
The importance of monitoring for change.
And they say to write down to trend, temp, pulse, and breath, breathing 4 times a day.
I think we've kind of taken apart to death.
Yeah,
Appropriate vital trending and
Yeah.
when that's okay versus when you need to do more, et cetera, and so forth.
yeah. And that's where the telemedicine consult comes in, because that'll, if you have a question on how often to take vitals, the telemedicine consult will answer that question for you. That's why those things exist.
And I just want to do a foot stomp on page 41.4, changing position in the bed.
Yes.
Because that's something that's really easy to lose track of.
Yes.
Because and just to make it explicit for anyone who's not clear, if you got somebody who can't move on their own and they're stuck in a given position, they're going to they can develop a pressure sore.
Mm-hmm.
Yeah, basically will.
This is also talked about in the prolonged field care CPGs. And I think it's you that has talked about, at least talked to me. I don't know if it was on here or in private, about doing like just some basic joint manipulations, like kind of like moving their arm and like bending their arm and moving joints, because that kind of adds blood flow.
Yeah, get some lymphatic return.
Mm-hmm.
Yeah, that sounds like something I would talk about.
Keeps a little bit of muscle tone. It's better for recovery too. It keeps a little bit of muscle tone, prevents joints from getting extremely stiff and ligaments.
Yes. I say a lot of things. I don't always remember everything I say. All right. So signs of dangerous illness on page. Seek medical help immediately on bold. It's page 42.
Yeah, and there's a whole list of.
So I'm just going to go through it real quick. Number one, loss of large amounts of blood from anywhere in the body. I think that's pretty obvious. That's why that would be an issue. Coughing up blood, pretty obvious why that would be a problem. Marked blueness of the lips and nails. So technical term cyanosis. This person is most likely not getting proper oxygen in their blood. Great difficulty in breathing that does not improve with rest. Fairly obvious as to why that would be a problem. Person cannot be wakened. Pretty obvious, or it says in parenthesis, coma. Pretty obvious why that's a problem. Person is so weak he faints when he stands up. Now that may or may not be weakness. That might be a low blood pressure.
Orthostasis.
Yep.
Yep. Or possibly a carotid artery issue. Which you're going to need a vascular surgeon for. But if you've got somebody who has such a low blood pressure that they faint or they get dizzy when they stand up, they're either on too many blood pressure medications or they're hypovolemic for some reason.
Or they're truly hypotensive.
Or they're for other reasons. I mean, they could have a cardiac rhythm issue.
They could have a neurological issue. There's a syndrome called POTS that the young adults, in particular, teenagers and young adults, will just get dizzy and pass out when they're walking around.
Positional orthostasis.
Positional orthostatic tachycardia syndrome.
Thank you. Positional orthostatic tachycardia syndrome. POTS.
They treated somebody with that before.
Not to be confused with pot, which might also make you dizzy. I don't know. All right. So 12 hours or more without being able to urinate. Yeah, that's a problem. A day or more without being able to drink any liquids, just because you really need to, you don't have a lot of physiologic reserve of fluids on board. Heavy vomiting or severe diarrhea that lasts more than 1 day or more than a few hours in babies. Same reason. Black stools like tar or vomit with blood or feces. That's interesting.
Self-evident right there.
So if you have black stools like tar, that is digested blood, you are bleeding somewhere in your gastrointestinal system. Vomiting with blood, that's pretty obvious. Vomiting feces.
You got bigger problems.
I've never heard of that, much less I have really.
Yeah.
Straight up not having a good time right now.
I've seen it.
You've seen it?
Unfortunately. That's usually when someone has a diarrheal illness and they're not actually vomiting feces, but what's coming out of both ends looks very similar. But I think what it's going for is like upper GI obstruction.
Okay.
And so it's not feces, it's chyme. That's what's in your intestines.
Okay. So it's like small intestine.
Yeah, it's like literally there's nowhere for it to go.
Yeah. Okay. Okay. So so not literally what's in your colon because it hasn't gotten that far. Right. But that partially digested food, so it's gonna look very similar. Yeah. Okay. That's all right. Strong continuous stomach pains with vomiting in a person who does not have diarrhea or cannot have a bowel movement. So that could also be a bowel obstruction, I guess.
I mean, could be labor.
Yeah, context is key.
Just saying that.
Strong continuous pain that lasts for more than 3 days. Stiff neck with arched back with or without a stiff jaw. So we were talking about meningitis and or tetanus in the last time. More than one seizure or fit in someone with fever or serious illness. Because going back to kiddos, I mean, febrile seizure in kiddos is not uncommon.
It's not uncommon, and if they've had one, they're more predisposed to have more in the same illness. So honestly, if it is literally just, if they've never had seizures before and it's a seizure that just occurs with a fever that has just spiked and they're doing that, I don't care. As long as they go back to normal, I don't care.
So their characterization of more than one within the same illness.
No, these kids are predisposed to have more than one in the same illness. So, if this is above the age of about 6 or 7, that's when febrile seizures really peter out. These are young kid things.
Okay.
Like if they're older than that and they're having any kind of seizure, they need to be evaluated because that's abnormal. Okay. A lot of what looks like seizures is not seizures, but that's impossible to tell without actually getting into it more. But it's like, quite honestly, if you don't have access, if you don't have easy, ready access to medical care, and it's a young kid, they have a fever, they've been having seizure-like activity with fevers, as long as the fever's coming down, you can move on with life. If you have access to medical care, get them checked out. But in the grand scheme, I'm not nearly as worried about that as someone older with a new onset seizure.
All right. Very good. So high fever above 39°C. There you go. It's in centigrade.
Thank you.
That cannot be brought down or that lasts more than 4 or 5 days. Weight loss over an extended time. Now, weight loss over an extended time, we're talking like 10, 20, 30 pounds. We're not talking about the 5 to 10 pounds people fluctuate over the course of a year, maybe.
10% of body weight.
10% of body weight for
it's usually documented.
Okay. So the most concerning thing to me that pops into my head is cancer. Because what do cancers do? They grow and they go through a lot of calories in that process. So assuming this person hasn't changed their dietary habits and they're losing weight despite a normal oral intake, something's burning those calories. And then of course, the other less dangerous but still significant thing would be a thyroid disorder, specifically hyperthyroidism, where that metabolism is the furnace is getting turned up. Blood in the urine. Well, that's going to probably get anybody's attention.
You can see it. That needs to be looked at.
Sores that keep growing and do not go away with treatment. Yep. A lump in any part of the body that keeps getting bigger. Yep. Very high blood pressure. They list 220 over 120 or greater.
Oh my goodness, they're generous.
Jesus.
Yeah, I mean, I was taught 180 over 120 as our emergency, but yeah, certainly if 220 over 120, for sure, that's a problem. And now I don't know if what they're saying is like both of those or either.
I would take either.
I mean, either would make me concerned. I mean, I've seen stable folks who had very high blood pressures. But like I've also taken somebody to the ER in congestive heart failure. Their blood pressure was over 200. It was like 205, something like that. So that's above the 180. And and that person was hospitalized. They weren't. It wasn't life threatening then and there, but something needed to be done. It wasn't. It wasn't significant. It wasn't mild enough to wait until they could see their regular doctor or just do oral Lasix. So anyway, as hospitalizations go, it was relatively straightforward. Problems with pregnancy and childbirth, such as any bleeding during pregnancy, high blood pressure, 140/90 or greater.
Thank you.
And so we're looking at so with that high blood pressure in pregnancy, we're looking at preeclampsia.
Pregnancy-induced hypertension being the first one, and then preeclampsia being your step up to the next level.
Yep, and then with
HELLP syndrome.
Yep, but also like that seizure. So HELLP syndrome is
high liver enzymes. Oh my goodness, I just had it in my head. What is my problem?
The elevated liver enzymes.
It's hypertension, elevated liver enzymes, and proteinuria.
Okay. The elevated liver enzymes is what's always concerned me with that. Like that's what always has stuck out for me in that. But so preeclampsia, of course, the concern there is like it goes to eclampsia and they start seizing. Really, and the only solution to eclampsia is deliver the baby. Preeclampsia, you give them magnesium, you give mom magnesium, and just be prepared that baby's going to be floppy.
Yes, that baby's going to need respiratory support.
Yeah, that baby is not going to have good tone, not going to APGAR well.
And mom is not going to be capable of doing anything. A mom on mag may as well be sedated and intubated for all that she's capable of taking care of herself.
So those are just things to be aware of. So long delay once the waters are broken and labor has begun.
More than 18 hours. So
the concern there is infection, because now we have broken our protective barrier, and we get concerned about infection both before or after delivery. Severe bleeding in pregnancy and in childbirth. Yes, that's also fairly self-explanatory. All right, so when and how to look for medical help. I think they even talk about how to build a litter, which is pretty cool.
Yeah,
get your little sheet cover over the patient, which I thought that was a good idea. They got the picture there, the carrier on the front. They've got the little. It's the same thing as on the cover of the book for this edition. It's basically the same thing. You can see where they rolled up a little bit of a towel or some padding on that crossbar, which makes a lot of sense if you're going to go a long way. I'm not sure how the guy in the back is going to get out of that, short of like lifting it up and over his head. That seems like that's going to be a little awkward to get out of it. But I will say for that move, that's probably going to work pretty well.
You can set it down on an exam table or something that you can just duck down and get up.
Yeah, if you had like an elevated table or stretcher to put it down on.
Yeah, that'd be the most convenient.
Litter stands would probably work really well for that.
Yeah.
They're literally just they look like sawhorses.
I was gonna say sawhorses. Yeah.
Works.
The truck bed, whatever.
Yeah.
Okay, so what to tell the health worker? Never send a small child or a fool.
I love that.
I love that line. That's in your edition, right? So never send a small child or a fool,
and it's in bold too.
Now I'm not sure who you think of when you think of a fool, but
there's lots of choices. I have lots of choices.
You're spoiled for choice on that. Moving on.
Moving right along.
I did that. So when you send someone for medical help, always send a completed information form with him. So
handoff.
There you go. So you don't want to rely on just an oral report. So you don't, because I mean, as we know, comment section is getting spicy. So as we know, the handoff is a complicated. It's a skill. It's a skill. The oral handoff is a skill. So definitely you want to send that report.
I highlighted write down the details of his disease and general condition. And that's kind of what like this next page, this patient report is. You don't have to use this form. We talked about last week the SOAP note, the SF600 form. You can use whatever form you can find online. There's a telemedicine consult form on the prolongedfieldcare.org. There is a non-military treatment facility form. Use whatever floats your boat, just as long as like the person you're well, no, I won't even go that far. As long as it's a form that's understandable,
Yeah.
because you might not be necessarily handing off to someone that you know, or that you've had the ability to train with. Well, we don't really know. Like, we don't have the ability to like look into the future, and tell what our situation is going to specifically be like. You don't know who's going to show up at your little area with skills you might not want to turn away. So I will say I won't limit you anywhere. Your imagination's the limit. You can use this as a starting point. You can literally just use a blank piece of paper in one of these and like jot down like most of the stuff, because limiting yourself to the lines that are on this can be potentially problematic.
It's like the pirate code. It's a guideline.
It's a guideline. It's a
Yeah.
decent guideline.
It is. If you've got nothing else, this'll
yeah.
And that's why I said to just use the questions and then just answer them on like another, like you go to like a poor school and like they don't want you writing in the notebook, so like you just like take your little ring binder and like you like answer the questions off the side.
It's a very specific example. So I will reiterate my issue, my one real issue with this form, and that is that the level of severity, sick, not sick, very sick, is at the bottom of the form.
Yes.
And I mean, it's consistent. I mean, if you're going to put it there, I'm going to know as the receiving provider to just skip everything else and look at the bottom, and then I'll backtrack.
Well, it's also not like, the person's going to just like hand the doctor this form and be like, here you go, and then just turn around and just like run off into the woods.
That would be the definition of sending a fool.
Yeah. So that's
well,
and this is where
we'd like to think not, but anyways, I would make that one change to move that status.
Yeah, just move that up to the top.
Yep. All right. Oh, any other comments on the form? I don't have any issues with it.
No. It kind of hits all the important widgets.
Yeah, I'm not going to read it verbatim. This is not Where There Is No Doctor audiobook, believe it or not. But yeah, that thus concludeth chapter 4 according to my edition.
Yeah. And it to be fair, this doesn't, I don't know if it's just something they don't do in the areas where these guys have gone, but it makes no mention of telemedicine. It does say something about having the health worker come to them if the sick person cannot be moved. That is potentially an option depending on your situation, but don't discount the importance of like just a good quick telemedicine consult.
I have a feeling this was written before a lot of good telemedicine options were available.
Yeah.
Well, I don't know, but I think this was probably written before cell phones, before sat phones were readily available.
Yeah.
And not everybody has the radio skills.
This is true. Especially depending on where you're at, where they're at. Depending on what's going on, those could be controlled items depending on what's going on.
Yeah, I wish I'd paid more attention in Guatemala to like the communications. I wish I'd paid more attention to like the radios that the military was using, or how that was working, because I just you're that new, like just finished the first year of med school, and you're like, I'm just happy to be here. Just along for the ride, trying not to trip over my own feet, and trying not to, not much less paying attention to the larger points of what's going on.
Yeah.
Rolling my eyes a little bit about at the terribly printing through pistols that are armed guards were carrying. Very confused about why their pistol reload mags were each facing a separate direction.
Mm-hmm.
It's like, pick one.
You don't know which hand you're gonna have to shoot with. You could need to reload with either hand.
I guess I just don't know how that helps. It's like you have one I mean, it's a very pleasing pattern. Maybe it's all the aesthetics, So you got your first magazine with the bullets facing forward on your left hip, and the second magazine with the bullets facing rear. So the magazines form a nice little peak. I mean, it's aesthetically pleasing. I was not taught like that. These guys must be like that. They must be like very
step
top
above.
tier.
Yeah.
I mean, yeah, they're so good. They're so good. They look bad.
Yeah, that's what it is.
That must be what it was.
Anyhow.
Anyway, that concludes chapter 4. I feel like we have enough gas in the tank to tackle chapter 5.
I haven't read chapter 5, so
even better. You have no presuppositions.
oh Lord.
Blank slate.
I was gonna try to keep, since it's so short and 6 is also, just do those together.
Sure. Yeah, and this is probably we don't have to like wear people out every time with.
Yeah, no. It was not my intention for every single one to be, 2 hours long plus.
Let me sing you the ballad of
yeah.
There is no doctor.
That was
so all right. So I guess the goal being next time to do chapter 5 and 6.
Yeah, chapter 5 and 6 will be the next one.
Right.
It'd be interesting if they had, and I was just kind of flipping through when you were just talking. I couldn't find anything in here on telemedicine per se. So that's interesting. I'm not surprised that I wouldn't find anything like that in here. But I guess that's something I get to fix on my own. But that's not something to be like ignored, the importance and how like beneficial good telemedicine. We've had this discussion with the Patreon classes before we started recording them, and had a pretty good in-depth discussion about like telemedicine and consults and what they mean and what they are and what they aren't. And telemedicine consults happen a lot more often than people think or realize, even like in modern regular industrialized medicine. Just simply something as simple as like a doctor texting another doctor like, hey, I'm not crazy on this, right? And just getting like a reassurance on something. But for us, it's going to be a little bit more different, using some of the different radio modes that have been talked about online, looking into HF and some of the data modes that you can do with HF.
So I'm going over here to look at I'm just looking at the teleconsultation section of improvised medicine, that book I was talking about the other time. Local area, under basic needs, local area communication, makeshift signals, tracking patients. We're talking about like using blackboards and whiteboards, keep track of patient information, transferring patient information, teleconsultations. Here we go. So there's a whole, consultations no longer need to be on site or even on the same continent to provide useful diagnostic information and assistance with procedures. EMS systems, aircraft crews, ships at sea, remote expeditions, disaster relief teams, and clinicians in resource-poor areas potentially have access to knowledgeable medical consultation. EMS and others have long used telephone and radio consultations. Now we have consultations using imaging and in some cases video. See, quote, photographing wounds for tele-estimates of size, in quote, section in chapter 25, for a description of how photos are used to assess and guide treatment in burn patients. Let's see. So then they give a picture of patient information written on post-surgical dressing. So they just a patient torso, Damage control, liver laceration, 20 lap pads in abdomen, skin only closed. So just real basic information there. Taking and transmitting digital images, the wide availability of the internet, digital photography, camera phones, blah, blah. All right. So
another thing that's going to make that even more interesting, especially for us, when I say us, I mean like partisans, is the remote and those like the mini ultrasounds. Just simply adding that into your capabilities. Holy shit. The things that you can do. No, it's not some fucking end all be all like the answer to everything, but for the simple capabilities of something that size brings, and the fact that you can just simply screenshot images and then send them like, hey, I don't have to try to explain to you through text what this looks like from the inside. I can just take a picture and send it to you.
So with ultrasound, it's also one of those things like most people, if they're familiar with ultrasound at all, they're familiar with ultrasound in pregnancy, right? And that's a very, very common use of it. The other most common one would be echocardiograms, taking ultrasound of the heart, or other blood vessels. But we've gotten to the point where we can ultrasound with certain techniques, bone, ligaments. Oh gosh, I placed on a model. I placed a central line with ultrasound guidance, so it allows you, if you don't have a lot of practice, which let's be honest, most of us are not going to have a lot of practice. Maybe even getting peripheral IVs, having an ultrasound to help you with that. If you don't have a lot of chance to practice it,
being able to do nerve blocks over like
doing
entire extremities or sections of ribs.
Yes.
That was, holy shit, that was huge. Because now you don't have to worry about, that was the one that I was at, was the musculoskeletal. So now you don't have to worry about like, well, shit, now I have to worry about like, I've never done RSI a day in my life. Now I have to figure out how the fuck to do it. Well, no, I don't need to. I'll just do a nerve block of your ribs and call it a day.
Yeah, RSI being rapid sequence intubation.
Yeah, I apologize.
Yeah, just basically if you're intubating someone because you're going to put them all the way under before you do something. No, you
adults who have to do that.
Right, and with and in the example given at SOMA, that conference we went to, they were talking about, let's say you're going to do a finger thoracostomy to try to get blood or whatever out of the thorax. Before you do that, you can do a nerve block all the way down the side if you know your landmarks and you have an ultrasound to help you get that needle exactly between the layers of muscle, exactly where you need it, and just put that numbing agent into that space, into that potential space between the layers of muscle, and just bathe that nerve in that whole area. So you do have to know the technique, you do have to know your anatomy, but having the ultrasound, it's kind of like night vision or IR lasers. It doesn't negate the need for training, but it opens up a whole new world. It's kind of like a magic carpet. Yeah. Man, I'm a nerd.
Yes, you are.
So I wanted to just bring this up. Also, they have this figure, what they call a fracture passport, which I thought was kind of interesting. And essentially, it's a cast of a broken arm, where they write 3 sets of dates: date of injury, date cast placed, and next appointment. And then they have a drawing of the fracture over the place on the arm where the fracture was. So they have a broken, like, you want me to just screen share so you can see this?
Yeah, sure. Let me make sure I have that as an option.
But I've never heard of this fracture passport idea, but I thought it was rather interesting.
All right, should be able to now.
All right, stand by. Pull up the main one here. There we go. Fracture passport. Okay. See it now?
It is loading. There it is.
So just pretty much what it says there. Fracture passport. It's got just what I described. date of injury, date of cast place, next appointment, drawing of the fracture. So
wow.
you got your radial bone, your ulnar bone, drawn on there, the two ends as far as approximately where it broke, where that broke is. So thought that was pretty cool.
That is interesting. If you can send me like screenshot that specific page and then send it to, or like there's a link, you know what? I'll find something online of a passport. That way I can put a link to it for everyone that's listening later on.
Yeah.
That way they can see that as well.
Yeah, it's a really interesting concept. But yeah, that's why I bought this book. It's very I just a little bit that I've seen is pretty cool. They talk about communicating within the medical facility, paging systems, walkie-talkies, runners. Let's see. I've not really read this section. I just saw it and I was like, oh, this is kind of interesting. Mobile radios, amateur radio operators, someone we know. We know someone who has some interesting information on that. Radio communication techniques. Someone wrote a whole book on that. Telemedicine, transmit. Okay. They have a little code here for little symbols. Ground to air
Yeah,
signal.
that's
now so
for
US
search and rescue.
Okay, that's U.S. Army. Okay, for like the letter I or the Roman numeral 1 require medical attention. Roman numeral 2 require medical supplies. SOS, most people understood. I understand that. Amplifying cell phone sounds. That's interesting. Amplifying the sound by resting it in a size 5 adult face mask. Using it as a parabolic reflector or Helmholtz resonator. Never heard of that before. So just interesting little things, satellite phones, etc. I was listening to the Prolonged Field Care podcast. They had an episode they entitled UW Hospital. I will admit I had high expectations that were not necessarily met. But that's okay. The whole point of it was that whole conversation was very notional. They had you can listen to it, but there are no hard and fast answers.
Yes.
Even to the people that have like nation state funding. But it did encourage me to they did this Air Force doc did mention a couple of books that I now want to go read. One is Gorilla Surgeon, which was a I can't remember if he's New Zealand or Australian doctor that was working with Yugoslavian guerrillas or partisans in World War II. And some of the stories from that, the lessons learned from that. Another she mentioned was Black Scalpel. And that's something else that I need to look at. Those are I want to dig those up and read them.
Alrighty. And what was the name of that book again?
The one that you mentioned was the two that you mentioned was Gorilla Surgeon.
No, it's the one that you just screen shared.
That is Improvised Medicine by Kenneth Iserson.
I think you read out that one last week.
Yeah, that's the one I laboriously read out.
Yeah. Oh my!
I read like the ISBN. I was listening to myself.
There you go.
The podcast.
Yeah.
I was trying to remember what it was that I said I was going to read up on. So I was listening to myself, like reading this ISBN. I'm going like, oh my goodness, this is really boring.
No, you know what not to do.
No, I know what not to do. I'll probably do it anyway. I'll probably do something else more equally boring. Closing a loop on the last podcast, I said we were talking about jaundice in infants, and we were talking about like, oh, can you unlike an ultrasound for humans, do you need a doctor's order to be able to acquire a
Transcutaneous bilirubin.
a jaundice detector, a jaundice monitor.
Jaundice stick.
And the answer is no, you don't. They are expensive for what they are. It's like $1,600 for what I saw. It was like eBay. Saw some, and then I think they were on Amazon as well. But I think Draeger was one name that came up, and you said
Draeger's a really good name in pediatric supplies.
Yeah, because you specifically mentioned the pediatric ventilators that they make.
Yeah.
So it's like a friend of mine that I once took to the range who didn't know anything about guns, and all she wanted to know was what are the best brands. And when you don't know anything about something, it's about all you can ask her, like, what are the best brands? Because that's where I am on some of this stuff. I'm like, okay, what are the good brands, and what is the Amazon only kind of thing? Yeah. What was it? One of you guys mentioned on the last Sons of Liberty, the Wish Biolab.
Yeah.
I didn't find that article because I'd like to read up on that. It sounded kind of interesting.
Yeah, the pictures were about what you expect from an improvised Chinese bioweapons lab. It looks rough.
Could you use like one finger to stick a hole through the wall, or would you need both?
I think the only walls were the concrete that like made the building.
Okay.
It was just kind of like a big open space.
All right. We researched
there was no containment.
Oh yeah.
It was just a big room.
Priorities. Man, well, if you're conducting unconventional warfare, or what's the other term? Not unconventional, not
unrestricted.
Unrestricted. Thank you.
Yeah.
If you're conducting unrestricted warfare, maybe containment, as you pointed out, is not your primary goal.
Mm-hmm.
Knowing as one of you guys said, G.I. Joe says, knowing is half the battle, and the other half is violence.
Lots of violence.
Knowing is half the battle, and the other 90% is violence.
Lots of violence. So much violence. Okay. So I don't have anything else for this. So like we said, the next one will be 5 and 6. When you catch us the next time, we'll be reviewing those 2 chapters if you are following along on your own outside of this. All right. I guess we'll, unless nobody has anything else, we'll catch you guys next time. And thank you for listening. Thank you for listening to this episode of the Stuck Pig Academy of Medicine. If you would like to join the Patreon, the link is in the show notes. Also, check out my training calendar for in-person classes. We'd love to have you.